Hello everyone. My name is Nitish Khurana and I'm a postdoctoral fellow at the Utah Center for Nanomedicine at the University of Utah. The topic for this lecture is controlled drug delivery for chronic rhinosinusitis. So let me first introduce to you to what chronic rhinosinusitis is. And from now on, I'll refer to chronic rhinosinusitis as CRS. So CRS is a debilitating inflammatory disorder of the sinonasal mucosa, or in other words, it's inflammation that happens in the sinuses. It affects up to 15 to 20% of the world population, and the patients who suffer from CRS experience a significant decline in their quality of life. Here you can see the anatomy of the sinuses. Humans have 4 different sets of sinuses that are present on each side of the face. The first is the maxillary sinus, which is present behind the nose. The second is the ethmoid sinus, which is present behind the eyes. Then you have the sphenoid sinus, which is present further behind the ethmoid sinus. And lastly, you have the frontal sinus, which is present behind the eyebrows. So rhinosinusitis can be classified into 3 different categories based upon how long the symptoms prevail in the patients. If the symptoms prevail for up to 4 weeks, then we call it as acute sinusitis. If the symptoms last between 4 to 12 weeks, then it's called subacute sinusitis. And if these symptoms last for more than 12 weeks, that's when it's called chronic rhinosinusitis or CRS. Some of the common symptoms that the patient go through in CRS are thick nasal mucus, plugged nose, headaches, sore throat, cough, and facial pain. CRS can be classified into 2 different phenotypes. One is CRS with nasal polyps and the other is CRS without nasal polyps. Nasal polyps are these benign tissue which are teardrop shaped like that are formed from the upper lining of the nasal cavity. And some of the patients have these nasal polyps, and that's why we classify them as CRS with nasal polyps. And some of these patients do not have these tissue-like structures, and we classify them into CRS without nasal polyps. So I want to talk about some of the challenges in CRS and how does that lead to a decline in the quality of life of patients. So the CRS patients develop comorbidities such as migraine, cognitive depression, and sleep dysfunction. And this means that with along the symptoms that they go through, such like we just talked about, like plugged nose, headache, extra production of mucus, they also go through these problems as well, such as migraine, cognitive depression, and sleep dysfunction. CRS is actually more prevalent than diabetes. The quality of life is as bad for the patients of CRS as compared to other diseases like coronary artery disease or even Parkinson's. And more antibiotics are prescribed for CRS patients than any other disease. Here you can see a CT scan of a patient who has CRS. So the black region that you see means that there is no mucus present in the sinus. If you remember, this is the maxillary sinus, and this was the frontal sinus here. So the opacification of the frontal sinus tells us that this patient is filled with mucus. The sinus, particularly of this patient, is filled with mucus. So because of the presence of this excessive mucus in the sinuses, it becomes very difficult for the patient to breathe, and that causes a lot of these symptoms. Here you'll be able to see a CT scan of another patient. In this, here we start with the nasal cavity. This is the maxillary sinus. You can see that almost all of the sinuses in this patient are opacified, which means that all 4 sinuses on each side of the face are filled with mucus. Now think about the problems that this patient might go through in terms of the breathing. Now that tells us that the quality of life in these patients is extremely declined because of the presence of these symptoms and the presence of this highly viscous mucus in their sinuses. So let's look at some challenges in CRS. Mainly the treatment challenges that are often there when it comes to CRS as a disease. First, let's look at the challenges in medical management. So the patients who suffer from CRS are often prescribed saline irrigation, topical and oral corticosteroids, or antibiotics. Now, the problem with topical corticosteroids is that when these drugs are administered topically or intranasally, the residence time of these drugs is really low in the sinuses or in the nasal cavity because of the presence of this thick mucus. The mucus is produced so quickly in the sinuses that the drugs cannot stay there for long to have an actual effect. And also, these drugs cannot penetrate the mucus because the mucus layer is so thick, and it's difficult for the drugs to reach the actual inflamed site, which is in the tissue, and elicit its response. The problem with oral corticosteroids is that it presents with a lot of systemic toxicities. As you know, that when you take oral steroids, a lot of people go through side effects. That's why oral corticosteroids causes a lot of toxicities in patients with CRS. The problem with antibiotics is that patients often form resistance to these antibiotic drugs. So when the medical management or the therapeutic options fail for the patients in CRS, that's when they turn to surgical management. Now, about 20 to 30% of patients turn to surgical management. Just in US, in more than 500,000 endoscopic sinus surgeries are performed annually. Now, what is an endoscopic sinus surgery? That's when the surgeon actually removes this layer of thick mucus from all the sinuses, and if the patient has polyps, then the surgeon will also remove polyps, which you can see in this video. These are the polyps that are present in the patient. So the surgeon will go in and he has a camera, which is the endoscope, along with it, and he'll start pulling all the mucus out, and that will relieve some of the symptoms in this particular patient who is suffering from CRS. But the problem with endoscopic sinus surgeries is there are always surgical risks, such as cerebrospinal fluid leakage, intraoperative hemorrhage, and osteocyanosis. If you remember, the ethmoid sinus is present behind the eye. So if the surgeon is going to pull out the mucus from the ethmoid sinus, there is always a chance that he can hit the base of the eye and cause osteocyanosis. So surgical risks are always present in these patients. And then again, when these patients go through surgical management, it doesn't mean that their symptoms won't come back. It's highly possible that after 2 to 5 years of their surgery, the symptoms start coming back and the mucus production starts again. So once again, the patient might have to turn to medical management, and then if that only gives him partial recovery from the symptoms, then he'll turn to surgical management again. Now this becomes like a vicious cycle where we're only treating the symptoms, but we're not treating the disease. So since this is happening, that we're not being able to treat the disease itself and we're only treating the symptom, that's why we wanted to come up with a new idea of how we can actually treat the underlying condition, that is the inflammation of the sinus. Nobody is treating the inflammation of the sinus, they're just treating the symptoms. So if you remember, we talked about enhanced permeability and retention effect in the last lecture. And if you remember, it's basically the extravasation of nanoparticles from the blood vessels into the tumor tissue. Now, in inflammation, similar phenomenon or similar mechanism of action for nanoparticles can actually be observed. There is precedence of this phenomenon happening in other inflammatory diseases, such as rheumatoid arthritis or atherosclerosis or inflammatory bowel disease, and this has been used for drug development purposes. So similarly, like EPR effect, the nanoparticles or the macromolecules passing through the blood vessels can extravasate through these widened junction gaps or fenestrations and accumulate in the inflamed tissue. So what will happen in this case, as you might remember from the last lecture, normal tissue has these tight junctions between endothelial cells. And once a lot of effects such as angiogenesis or different inflammatory cytokines start working on these network of blood vessels, these fenestrations or these junction gaps start to widen up. Now, in normal vasculature, the endothelial junction gap will be anywhere less than 10 nanometers. But in the leaky vasculature, this endothelial junction gap will be more than anywhere above 50 nanometers, and it can even go up to 500 nanometers in some cases. So a nanoparticle which is passing in the blood vessel can preferentially extravasate through these fenestrations and accumulate at these inflamed sinonasal tissue. Now, in these nanoparticles, we can have anti-inflammatory drugs that can be released at the inflamed sinonasal tissue and treat the inflammation. And as I said earlier, this will not treat the symptoms, but the inflammation. And if the inflammation is cured, that will automatically result in improvement of the symptoms. So this way, we're not going into this vicious cycle of only treating the symptoms and then trying to surgically remove the mucus, but instead we're circumventing the current available treatments, and we're trying to treat the underlying inflammation. So in the last slide, I showed you that in normal blood vessels, the endothelial junctions are the tight junctions between the endothelial cells are really tight, or as we call them, fenestrations. They are really tight and they're less than 10 nanometers in size. And for inflamed tissue, the blood vessels that are present in the inflamed tissue, the fenestrations between the endothelial cells often go up to 50 nanometers, more than 50 nanometers, and in some cases even up to 500 nanometers. So this is an actual example from sinonasal tissue collected from a healthy patient and a patient who was suffering from CRS. So a healthy patient, also known as a control, is this patient, and you can see that the tight junction gaps or the fenestrations in this patient goes up to 12 nanometers. Whereas this is a patient with CRS without nasal polyp, and this is a patient with CRS with nasal polyp. You can see that in the case of the patient with CRS with nasal polyp, the fenestration went up to 60 nanometers and it went up to 33 nanometers in the case of CRS without nasal polyp. And as I said, in some cases it goes even higher and can even go up to 500 nanometers in some cases. So similarly, we see other alterations or other disorganization in the blood vessels as well. If you remember from the last lecture, we looked at a slide where we compared the blood vessels in a normal tissue versus a tumor tissue, and we saw a lot of disorganization in the blood vessels which was present in the tumor tissue. So the blood vessels that are present in inflammatory tissue is also similar. There is absence of or fracture in the basement membrane. So as you can see here, this is a healthy patient from which the sinonasal tissue was collected. Now this is a cross section. This is a cross section of a blood vessel. This is a red blood cell. This is the actual blood vessel, and this is the endothelial cell that is covering that blood vessel. Now you can see that around this blood vessel, you see this thick basement membrane, whereas in both cases of CRS without nasal polyp and CRS with nasal polyp patients, that outer layer is absolutely gone, which means that the basement membrane in these patients are just absent and even fractured in some cases. We see wider gaps between the tight junction, and we see an increase in the endothelial barrier lining as well. You see that the endothelial cell, the lining of the endothelial cell in the healthy patient is very thick if you compare this size, whereas in both CRS patients without nasal polyp and with nasal polyp patient, the thickness of the endothelial lining is very thin. So this in general is called alteration in blood vessel morphology, because in inflamed tissue we're seeing a lot of disorganization in the blood vessel. So another phenomenon that is often observed is the increase in the number of blood vessels in inflamed tissue compared to normal tissue. As you can see here, that in a healthy patient, the number of blood vessels were significantly lower compared to a patient with CRS without nasal polyp and a patient with CRS with nasal polyp. Now, in this section, the brown color represents a blood vessel. So you'll see that in the healthy patient, the number of blood vessels were significantly lower compared to a patient with CRS without nasal polyp and a patient with CRS with nasal polyp. Now, why is this happening? First of all, the growth of new blood vessels is called angiogenesis. But why is this angiogenesis happening? So, for the inflamed tissue to survive and to grow, it needs oxygen, it needs nutrients, it needs a supply of water. So, where does this supply come from? The existing number of blood vessels cannot fulfill that need for that inflamed tissue. So, in order to increase the supply of oxygen, nutrients, and water to the inflamed tissue, new blood vessels are formed. And inflammation keeps on going, and that's why angiogenesis also keeps on going. And again, it becomes cause and effect of each other, or cause or consequence of each other, where angiogenesis is causing inflammation and inflammation is causing angiogenesis. So for the last three slides, when we combine them together, what did we see? We observed that there was an increase in the number of blood vessels, which we called as angiogenesis or neoangiogenesis. We saw a change in the blood vessel morphology in the terms of increase in vascular permeability, which was the widening of the fenestrations, and we also observed thinning of the endothelial barrier, and we also saw fractures in the basement membrane. Now, when we put all of these effects together, we call this as inflammation-driven vascular dysregulation in CRS, which means that it is the inflammation which is driving this vascular dysregulation in the patient with CRS. Now, we know that we have these widened fenestrations in the patients with CRS compared to healthy controls. Now, as we remember from the last lecture, people have taken advantage of this for tumors, where they have delivered different nanoparticles to treat the tumors because of the EPR effect. Now, the question is, can we do the same for the patients with CRS or any inflammatory disorder for that matter? So that's why the hypothesis became that if instead of the current therapy, which are the oral drugs and the nasal sprays, if we circumvent the current therapies and we deliver a nanoparticle via systemic delivery, which is directly into the blood, and then the nanoparticle will be traveling in the blood vessel, it will eventually reach the blood vessels that are present in the nasal cavity. Now we know that these nasal cavities, we have a lot of vascular dysregulation where the fenestrations are increased. So the nanoparticles can then extravasate and actually reach the inflamed site, which the nasal sprays cannot achieve because of the presence of mucus at this stage. But in this proposed therapy, the nanoparticle will target the inflamed tissue via the extravasation mechanism. So for that, we decided to use liposomes as our model system. You might remember liposome being one of the first ever nanoparticles that were FDA approved to be used for treatment of cancer. So liposomes are vesicles that are made of one or more lipid bilayer surrounding the internal aqueous compartment. So this is a lipid present here. Liposomes are most commonly present in a bilayer form where you can incorporate hydrophilic drugs in the aqueous compartment, or you can also incorporate hydrophobic drugs in the lipid bilayer, because this part is devoid of any water component. The advantages of liposomes are that they have low toxicity profile. They have the ability to incorporate both hydrophilic and hydrophobic drugs. It protects the drug from activation in the bloodstream because the drug is protected inside these layers. And we can do multifunctionality with liposomes, which means that you can attach all different kinds of things such as proteins, antibodies, imaging agents, targeting agents, that we've already talked about in the last lecture on the surface of these liposomes to improve their accumulation at the targeted site. So we decided to incorporate an imaging agent in the liposomes. The imaging agent we selected was Indocyanine Green. ICG is an FDA-approved imaging agent which has a really short half-life of 3.5 hours. If you remember in the last slide, we looked at an advantage of liposome that it can prevent the drugs from activating. Similarly, liposomes also have the advantage of providing a higher half-life to drugs and imaging agent. ICG is unstable at physiological temperatures. As you can see here in the mass spectrum of ICG, when ICG was incubated at 37 degrees for 24 hours, ICG started to fragment. And this is a known fact for ICG, and why it is unstable at physiological temperature or 37 degrees Celsius is because it tends to fragment and aggregate, and is hence physiologically unstable, which was confirmed by this mass spectrum. So finally, we decided to deliver this liposome, which had the indocyanine green incorporated into the bilayer, into the healthy mice and diseased mice. And diseased mice here had inflammation in their sinuses, or we created a CRS mouse model so that we can see whether the liposomes will accumulate in the sinuses or not. So we injected the liposomes in the tail, which is the route to inject liposomes in the bloodstream in animals. So the mouse model was developed, and finally we did imaging on the sinuses of these animals, and we did different assays to see whether the liposomes were accumulated in the sinuses or not. So as you can see here, these are the healthy animals, and these are the animals that had CRS in them. Now, these two sections just show us two different types of, or two different sizes of liposomes that we used. This is the free indocyanine green or free ICG by itself, and this is an empty liposome which did not have any imaging agent, which we use as a negative control. Which means that since the liposome does not have any imaging agent, we shouldn't be able to see any signal, because the instrument that is taking the image of these animals is looking at a fluorescent signal. Now, in the animals that had disease and that were delivered with the liposome and the imaging agent ICG, we see accumulation of the liposomes. Darker, the blue color means that we have higher accumulation of liposomes, and red means that that area has lower accumulation of liposomes. Now, you might think, based on this image, that hey, come on, even the healthy animals have some accumulation of liposomes in them. How is that possible? So it is possible because ICG can leak out of the liposomes when it is circulating in the bloodstream, and ICG has a mechanism of action that it can bind to albumin, which is one of the most abundant proteins in your blood. Now, when it binds to protein, it essentially becomes a nanoparticle by itself, because albumin has a size of approximately 5 to 9 nanometers. When a small molecule like ICG will attach to albumin and become an ICG albumin complex of about 5 to 9 nanometers in complex, it can extravasate through the fenestrations of the healthy animals, because if you remember the fenestrations of healthy patients, and we did this for the animals as well, the fenestrations of the endothelial cells in healthy animals or patients did not exceed 10 nanometers, but the albumin ICG complex is less than 10 nanometers, so it is possible for that complex to extravasate and accumulate in the sinuses. Now you would say that same might be happening in this case as well, that it is the ICG albumin complex and not the liposome itself. But if you look at the quantification, you see, say for example, we look at day 12, you see that the accumulation in the diseased animal versus the healthy animal was significantly higher, which means that it is the liposome that is accumulating inside the sinuses. Whereas free ICG, if you remember, tends to deteriorate after 24 hours and is unstable at physiological temperatures. So we saw some signal of ICG at 24 hours, and after that, all the signal of just free ICG was gone from animals. And just again to reiterate, for the last slide, we actually cut the heads of the animals, and we did some transmission electron microscopy on the heads of the animals, and we actually saw presence of liposomes in the sinuses. So that actually corroborated the story that the diseased animals had, in fact, accumulation of liposomes in their sinuses, whereas healthy animals did not. So essentially, in summary, what I want to say here is that we see an increase in vascular dysregulation in disease versus healthy, both in humans and mouse model, which we talked about in terms of increase in the fenestration sizes, increase in the number of blood vessels. And again, I say the same thing here, that we see an increase in fenestration sizes, which is important because EPR-like effect also exists in inflammatory diseases, which now people have started to realize and are exploiting that for improved drug delivery in inflammatory diseases as well. So finally, controlled drug delivery can be helpful for inflammatory disorders, and we need to approach treatment of inflammatory diseases from a new direction, because as I said earlier, what everyone is doing is treating the symptoms, and they're not treating the underlying condition, which is the inflammation. So we need to approach the treatment of these diseases from a new direction. I hope you enjoyed this lecture, and I would like to thank you. Thank you.